Today I'm delighted to have Dr. Rick Shepler and Mike Fox of the Center for Innovative Practice at the Begun Center for Violence Prevention at Case Western University. And the topic for today's On the Couch episode is co-occurring disorders. Can you tell us what you mean by co-occurring disorders?
Well, when we talk about co-occurring disorders, very specifically it refers to mental health and substance use happening at the same time. We promote an integrated approach to co-occurring use.
So the label is also important in the sense that it focuses our attention on the fact that you have to address both the mental health and the substance abuse disorders simultaneously in order to get traction and make progress in terms of treatment goals?
That's absolutely on target. We know from a lot of experience and a lot of research that you can't do one first and expect the other one then to just sit there and wait, or maybe reduce as kind of a side effect of just addressing one side. Rather, if you just address one side and not the other, that other side kind of hangs on like an anchor and changes just don't move forward. So if you tackle both at the same time, you give the youth and the family a much better chance of showing some positive change.
Is it important to do an assessment to make sure that you're getting a proper inventory of the service needs? I would think that as a mental health clinician, if I'm not comfortable treating substance abuse disorders, there might be an inclination not to actually ask the question to know whether or not there are substance abuse disorders, because then what do I do?
Well, at the broader level, I think there is an issue about screening and assessment for substance abuse or alternatively mental health because they are fearful about if they identify it, what do they do? And oftentimes if they identify it, they'll refer it out. And then you run into an issue of kind of a parallel treatment process going on, which means you could have two slightly different or entirely different treatment plans for that youth, plus the burden of the youth and family having to go to separate appointments, additional expenses and those things. So it doesn't seem to work as well. From a programmatic perspective, I think what we're talking about here is doing a comprehensive enough assessment up front that identifies not only the mental health symptoms, the substance abuse symptomatology and diagnoses, but as Mike was saying earlier, the other conditions that are going on in that child's life. So we talk about doing an integrated contextual assessment. And so we're not only assessing for the mental health and substance abuse, we're also assessing for functioning at school, at home, in the community. Our youth, many of the youth that we serve that have co-occurring mental health and substance abuse disorders are involved with the juvenile justice system. Many of the youth that we serve are struggling in school. What I always say is, our kids are the ones that get kicked out of stuff. So it's really important not only to identify it, but you do it in the context of a really comprehensive integrated assessment, and from that then you get your integrated treatment plan.
I almost wonder, are we even using the right frame or the right language? Are the mental health issues and the substance use disorder just flip side of the same coin? Are they actually derivative of some of the same psychological challenges or processes? Or are they truly distinct?
That's a great question. I think you could argue they are derivative of the same processes. One of the things that we know, for example, is that trauma is a major driver of symptoms for youth with co-occurring disorders, but it drives certain behaviors that can be assessed and treated. And those behaviors, if you just look at it and you don't label them, that's your palette that you have to work on. So I could see it as, especially using trauma as an anchor, you could see where things flow from that.
Because youth have maladaptive responses to trauma or to general life stressors or to precursors or the potential towards mental illness based on genetic predisposition that leads to maladaptive behaviors. It can include cutting, it can include high-risk taking behavior, it can include use of substances. So are they really that different, or are they actually just different reactions or different phenotypes of the same basic disorder?
No, and I think that there's increasing research looking into that very thing right now. You see matches, and at this point I think it's mostly correlational being made between certain types of mental health distress being matched with certain types of drugs that are preferred. And I think that speaks to maybe some of the pathways that you're talking about. And as you mentioned, stress, we know that especially if it is that pervasive traumatic experience that so many of our youth have, not a singular traumatic, life-threatening event or experience that we think about with classic PTSD, but just a constant, pervasive, traumatic life experience really builds a susceptibility to both drug and alcohol use and the mental health. So I think that those pathways are connected at a biological level.
That's a really interesting point, Mike, because I will, in my own clinical work with young people, when I learn that they are using a substance, one of the first questions I ask is, how does it make you feel? What is it that you like about taking that substance, that drug, alcohol? And it can actually help to inform my understanding of their mental health issues. Not that, there is the concept of self-medication, and I'd like to hear what you think about that. But it also informs, for me, anxious people don't necessarily like speed, for instance, because it makes them too anxious. And they'll tend to go for things that are more depressogenic, if you will. And people that might be more melancholic might actually try to use substances that actually energize them. And whether or not that's the concept of self-medication or just how it informs their preference, for a clinician, it informs me a little bit about what's going on for them from a mental health perspective.
Chris, you raise a very, thought-provoking idea that does co-occurring make the words, the framing of it, make it more complicated from a provider standpoint? Should we just be talking about this it's one person? I always say one person, one assessment, one treatment plan. Why are we sometimes trying to make it more complicated? And I'm wondering if we framed it just as behavioral health in general, and we train providers and clinicians to do behavioral health, and all of these things are a part of it, the child shows up and you do those things.
Well, thank you both. It's been a pleasure having you here, and I wish you the best.
Thank you.
Thank you for having us.